week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
We're going to go ahead and move on to Angel Rose Weber. She is coming to us from Albany Medical Center. Going to talk to us about comparison of IV paracetamol to IV or IM administered NSAIDs or opioids for patients presenting with moderate to severe acute pain conditions in the ED.
Well, thank you for the introduction. My name is Angel Rose Weber. I am a PGY1 resident at Albany Medical Center, and I'll be presenting a systematic review and a meta-analysis on the comparison of IV acetaminophen, which is referred to as IVP in this meta-analysis, IV or IM NSAIDs, or opioids for patients presenting with moderate to severe acute pain conditions in the emergency department. Our objectives today will be to describe the complexities of diagnosing and treating acute pain and to analyze this study and its applicability to clinical practice. So before we really dive into this meta-analysis, I think it's important to go over why pain is so difficult to properly treat. So firstly, pain is very diverse. Not all pain is the same, and pain should not be treated as such. Pain can be categorized based on its major characteristics and can be divided into three categories based on different characteristics. Firstly, we can classify pain based on its duration of pain we have, whether it's transient, acute, or chronic. And usually these things are based on whether there's tissue damage, nerve damage, or whether there's any tissue injury or no injury. Additionally, we can classify pain based on the type of pain we have, whether it's physiological or pathological pain. However, for the focus of today, because this is emergency medicine and because the meta-analysis focuses on that, we'll be focusing on more of the acute pain. Another thing to keep in mind is that patient pain treatment is very multifactorial. There's a lot of things to keep in mind. Firstly, patient demographics. Sex, gender, race, ethnicity, risk of addiction, and contraindications to pain medication will all play a role in a patient's ability to speak up about their pain or just what they can and cannot receive. Physician awareness could mean a couple of things. It can mean, firstly, are they up to date on guidelines? Are they up to date on hospital protocols? And are they physically aware of how much pain the patient is truly in? Can all play a role. Additionally, the underlying illness. Can the patient physically speak? Are they intubated? What type of pain they have? What is the severity of pain? All these factors will play a role in guiding treatment. So when it comes to the treatment option of acute pain, we have a couple of treatment options. First, we have our non-steroidal anti-inflammatories, also known as NSAIDs. These are great options because they're available PO, IM, and IV, but they have a lot of contraindications that can limit its use and some nasty side effects. When it comes to Tylenol, Tylenol is available PO, IV, and even rectally. There's a lot of really good implementations for that, but the IV formulation tends to be a little bit more expensive than oral options. And then opioids, as we know, is one of our big heavy hitters when it comes to pain management. However, there's a lot of bad side effects and addiction potential that can be caused with opioids. So between all these three treatment options, you got to kind of have to figure out what's best for your patient. The American College of Emergency Physicians had a policy statement on this. Their policy statement is a little vague, but it starts with choosing an agent that's a non-opioid agent originally for acute pain conditions. If you do choose NSAIDs, you should choose them based on their analgesic ceiling dosing and prescribe them at the lowest effective and shortest duration possible. They do recommend IV acetaminophen as an alternative. However, they do mention that if you do choose opioids, you really want to go over the risk and harms and counsel the patient appropriately for this pain conditions. So why this meta-analysis? We have all these options for pain medications, but why this specific study? So prior to this meta-analysis, there was a 2016 systematic review reporting on the use of IVP in acute pain presentations to the ED. Since that study, 23 relevant trials have then been released. And this review focuses more specifically on the IV and IM route rather than the PO route or any other miscellaneous route that may lead to heterogeneity in data. So the study objective is to evaluate the level of analgesia provided by IV, IVP alone compared to IV or IM NSAIDs or opioids with the IV route only in adults presenting to the ED with acute pain. So the outcomes, the primary outcome is the mean difference, which will be shortened as MD for this presentation, in pain reduction for each group, that being IVP versus NSAIDs or opioids, after 30 minutes post-analgesia delivery. The secondary outcomes is that same mean reduction, but after 60 minutes, 90 minutes, and then 120 minutes, along with the need for rescue analgesia at those same time frames. And the safety is just the occurrence of adverse effects. In this meta-analysis, they didn't define what those adverse effects were. They defined adverse effects as anything the clinical trials that were incorporated in this meta-analysis deemed as adverse effects. For the study timeline and the databases used, they performed a systematic review and a meta-analysis of only randomized control trials. The initial literature search was conducted between March and April 2021 using Medline, Web of Science, Embase, and the cohort library, and supplemented by hand-searching references of relevant articles. And then they did the same exact review about a year later in May 2022. For inclusion and exclusion criteria, they kept it very minimal. They included patients that were 18 years or older. They only included randomized control trials. Studies included had no restriction on language. Trials that administered oral medications in any treatment arms were excluded because we only wanted to focus on the IV and the IM route. The quality assessment was performed using the risk of bias, the ROBV2. This approach involved the consideration of within-study risk of bias, heterogeneity, directness of evidence, precision of effect, and overall the risk of publication biases. Very similar to guidelines, they did use the grade assessment, and the recommendations that overall that was made was based on whether they were strong or whether they were weak. For statistics, they used the Stata V17 software to calculate the overall pool effect and the inverse variance heterogeneity model. They did perform a subgroup analysis on pain etiology, which included these 5 categories of renal colic, headache, back pain, abdominal pain, and musculoskeletal injuries. And to consider the variation between the different type of NSAID drugs that were included in this trial, they performed a sensitivity analysis. So for our actual trial selection, originally, after they went through all their databases twice, they originally found 3,869 records, all these trials that could potentially be included in the meta-analysis. So first, when they had all these 3,000 different studies, they first screened them based on the title and the abstract. And from that, 3,829 of those trials were excluded. So they only had 40 trials left that they can really analyze the rest of it to see if it was applicable to their study objective. So when they had 40, they excluded 13 of these trials, and they ended up with 27 for the systematic review and 24 for the meta-analysis. Reasons for exclusion included failure to include primary outcomes, the trial medications that were a part of the trial were not intended for the study protocol, medications might have been given by the oral route, or trials that were not randomized control trials. Some reasons why there were 27 included in the systematic review and only 24 in the meta-analysis was some of them had a high rate of heterogeneity that precluded it from it being in the meta-analysis. So for the primary outcome, overall, there was no significant difference between pain reduction after 30 minutes of post-analgesia between the IVP group and opioids. However, it is important to note that although the primary outcome wasn't significant, there was a high degree of heterogeneity. You can see that all those I-square values are very much significant. And possible reasons for that could be pain etiology, the different dosage of medications, the different type of NSAIDs, and just the different administration techniques that might have been implemented at different institutions. So as we dive into the secondary outcomes, one secondary outcome that was significant was pain reduction between IVP and NSAIDs at time equals 60 minutes. One thing that's important to note, even though we had 24 trials included in the meta-analysis, only 5 of those trials were actually included in the secondary outcome, just because the rest of the trials didn't look at specifically IVP versus NSAIDs at time equals 60 minutes. We can see based on this plot that it is statistically significant, but once again, we're only really basing it on 5 studies, only 2 of which actually showed statistical significance. Another secondary outcome that had a significant result was the need for rescue analgesia for IVP versus NSAIDs at time equals 30 minutes. Although we had a couple more trials that were included, you are able to see that it is still statistically in favor that NSAIDs did not need more rescue analgesia than IVP. But once again, it's important to note that not all of the 24 trials actually showed showed this, and not all 24 of those trials were actually included in this secondary outcome analysis. So this data suggests that maybe NSAIDs may be the preferred agents over IVP. However, where does IV opioids play a role in this comparison? So when we think of opioids, we think of those nasty adverse effects. And a lot of the trials in the meta-analysis actually did look at these adverse effects. And overall, there was a statistically significant increase in adverse effects compared to opioids than with IVP. There were 50% fewer adverse effects reported in patients receiving IVP than compared to those receiving opioids. But once again, the study didn't really define what adverse effects were. They included that anything that was deemed adverse effects in clinical trials that was included was an adverse effect of this meta-analysis. So the adverse effects could be as mild as headaches, but can be as extreme as an overdose, theoretically. So strengths and limitations. Overall, this was a very large patient population. Over 5,000 patients were included. They included randomized, double-blinded control trials with one exception where that was not double-blinded, and it had a very fair and simple inclusion and exclusion criteria. Limitations included the large degree of heterogeneity between pain etiology, participant characteristics, medications, and dosing. Additionally, a lot of these trials, although the meta-analysis had a large sample size, they were small and single-centered. There was no standardization between the adverse effects reported, which only 21 trials reported adverse effects, and there's no direct comparisons between NSAIDs and opioids. Throughout the meta-analysis, it was always comparing IVP to opioids or IVP to NSAIDs. None of the findings were actually comparing NSAIDs directly to opioids. 20 out of 27 of the trials included had high or unclear risk of bias using the ROBV2 tool, and this trial only included adult patients, which is expected, but still it cannot be applied to pediatric patients. So overall, the conclusions that I would make from this is that this meta-analysis and systematic review shows that NSAIDs may be considered first-choice analgesia in patients with acute pain presenting to the ED, with IVP as a viable alternative in patients with no contraindications. Additionally, this trial showed that opioids do not appear to offer superior analgesia and had more risk of adverse effects. However, this meta-analysis should be by no means guideline changing. The biggest thing to take away from meta-analysis is that it's only as good as the sum of its parts. And the sum of its parts did a really good job at addressing important questions, but there was a lot of heterogeneity and more issues that really needs to be addressed. If these results would want to be incorporated into guidelines, there would be a need for more homogeneous randomized controlled trials with direct comparisons between NSAIDs and opioids. Here are my references, and does anyone have any questions for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.